Hi, welcome. Thanks for joining us today. Our topic of discussion is how a strong physician-APP partnership coupled with the care pathway integration can lead to identify more appropriate patients for advanced treatment options such as InterStim therapy. We are joined by two healthcare providers who are committed to patients and excellence. Dr. Jana Thompson is the director of the Continence and Pelvic Health Center at Urologic Consultants in Grand Rapids, Michigan. Amanda White is a physician assistant who works with Dr. Keith Xavier at Urology Partners of North Texas in Arlington, Texas. Today, you will learn how this partnership had such a significant impact on each of their practices that not only did it make it necessary for the APP to collaborate where patient selection is concerned, it also provided an opportunity for Amanda to build an InterStim practice where she performs all of the basic evaluation tests in her clinic. Sit back, relax, and be empowered to become the InterStim expert in your practice.
Hello, everyone. I'm excited to have an opportunity to share with you my experience alongside Amanda. Amanda and I have worked together not in an office setting with patients, but definitely with teaching other physicians and APPs. And so I know you'll have a sort of a similar but different things to draw off our experiences. So I am from Grand Rapids, Michigan, where I'm in a urology practice. I practice female urology, urogynecology there. And I started about 10 years ago after my fellowship in female urology in the Twin Cities with Dr. Steve Siegel. I am also an associate professor for the urology residency there in Grand Rapids as part of Michigan State University. So tonight is something that the topic tonight is something I'm very passionate about, which is the overactive bladder population of patients that I see on a daily basis in the practice. And what I'm particularly interested in is how to make their experience in the office more efficient from the standpoint of getting them to treatment that is really beneficial, but also how I can deliver information that they can remember, refer back to, and use when they're away from the office to help guide them and maybe trigger some healthy habits. So with that, I'll let Amanda introduce herself.
Hi everyone, I'm Amanda White. I've been a physician assistant since 2011, worked with Medtronic since 2012. I was so very lucky to end up with Dr. Xavier from the get-go and haven't left since. So I've been in urology since 2011 and I wouldn't change it for the world. I absolutely love what I do. I love seeing the patients I see, and the space I'm in now is very subspecialized. So I strictly see voiding dysfunction and kind of female urology prolapse type things. Again, it's my passion. My picture kind of says it all there for you. I really love doing what I do, and I'm really excited for Dr. Thompson and I to team together so that we can help advance these APPs so we can have more endeavors in the future. Urology space is getting a little small, so APPs are going to be very well in demand, and honing in on our skills is going to be extremely well sought out at this point. So we're excited to get you guys started and hope you learn a lot from us today. Dr. Thompson?
Thank you. So where we'd like to start this conversation tonight is really about the guidelines. So guidelines are basically a pathway or a tool that physicians, APPs have at their fingertips on any disease process that's out there. And the idea behind guidelines is that we can practice safe and consistent medicine, whether we're in Texas or Michigan or Maine or California, that patients with a certain disease state would receive a standard of care. And so our own governing societies, the AUA and AUGS, and the Gastroenterology, ACG, and the American Society of Colorectal Surgeons all have standards that we follow. And so the guidelines, specifically when it comes to overactive bladder, are important because prior to having this standardized document that we could all refer to not only make sure that we're giving our patients the most up-to-date care, but also the research papers to look at when we want to know where did this recommendation come from. And so these really are to guide us, and it was these guidelines specifically for overactive bladder and fecal incontinence were developed by a group of leaders who did look through all the literature that's out there and come up with recommendations. So it should give us quite a bit of trust, as well as assurance that when we're treating our patients, we're really doing that out of the best possible knowledge that we have at this time. So these guidelines not only help to build trust among myself and the patient, but also among the team that is there to treat the patient. And that team can be made up of many people. That could be the MA, the RN, the APP is most definitely an important aspect of that, but even the phone triage person. And so as we begin to use the language of treatment algorithms with our patients, they continue to hear that same consistent message when they're coming in and interacting with other healthcare providers in the office besides the physician. And so this care pathway that we're going to speak of next was really a way to make these guidelines more tangible and understandable in patient language. With that, Amanda, maybe you can give your story about how you and Dr. Xavier developed yours.
Sure. So at the time, I was working with about 4 physicians. And so a lot of you APPs understand working under 4 different physicians means 4 different protocols, 4 different ways of treating the patient, and sometimes a little bit of personalities as well. So it was a little hard for me to understand at the very beginning what we wanted to do and to be consistent. And honestly, it ended up being a little bit of a selfish move for me to get everybody on the same page. So we just, I had to sit down with all of these docs, and as you know, that's very hard to do as well. Once we got together, we used the AUA, we used SUFU, we used OGS, we used the Colorectal Society. We used all of those together to help us develop a care pathway in the very similar form you see right now. In that instance, we learned that we could come together as a team and really help understand that you don't, with one physician works through by giving 5 different medications, and the other physician moves forward only after the first 2, we figured out that it was better for our practice and better for the patient to have something consistent across the board. And our care pathway is very clear and concise. As you can see right there, that's an example of it, to not only help us as clinicians, but to help the patient understand where we're going with it. It ended up being a little bit of a win-win for us, not only with the practice and the patients, but we use this with our colleagues who are in the same practice who don't subspecialize in the incontinence world like we do. So they could understand if they saw a patient who had any sort of voiding dysfunction, how they could direct them in the right path, and then keep us on board at the same time. And then in the same instance, we use that with some of our referring physicians, handed out these pieces of paper to them as well, so they could understand, hey, we have a plan, we have a plan of attack here, and also help their patients understand that as well. So it ended up being a little bit of a business card in the instance where we would give that to our referring physician. So your team is not just the people in your office, it ends up being the people in your practice and then the people who refer to you as well. So keep that in mind. So you see the care pathway there, and it's pretty clear and concise, like I said before. Really, you start with the conservative options at the front. We'll walk you through those in a second. Medications, reevaluation, and then advanced therapies. So what we like to do in our practice is we like to really personalize this, put their name on it, maybe even include a little bit of a goal, but also a realistic goal. So if Miss Helen here is soaking through about 10 depends in a day, are we going to get her to 0 depends in one day? Realistically, not really. So this helps us to again, walk the patient through our plan as well as our expectations along the way. So, if we can click through a couple of times, we use those bladder control strategies, managing constipation, whether that means providing them with an option for Miralax, stool softeners, increasing the fiber, moving forward to doing fluid management or diet management, decreasing that caffeine, any of those bladder intakes. I can't tell you how many times I mention the words coffee, soda, tea all throughout the day. Those are bladder irritants, and you can't drink a whole pot of coffee and expect to not rush to the bathroom all day. So along with that comes pelvic floor therapy options as well. Always a great idea. We always want to encourage that. That can definitely not hurt us in the long run of things. Then we moved to medications, and then maybe a reevaluation with oxybutynin might be some medication that they take. But remember, some of these patients may come to you, have already taken something from the primary care doctor. Again, I'm pretty subspecialized in my division, so by the time most of these patients see us, they've tried 1 or 2, or they're coming to us directly for a reevaluation, which would be urodynamics testing. So anywhere along the way in this care pathway, you can see we can really personalize and point out to the patient where they are in this instance and whether we want to move them forward. So after medications, medications usually is a prompt for me to ask about side effects like dry mouth and constipation. Constipation, once I ask that question, I usually prompt it like, do you have any difficulties with your bowels? And they say, oh, actually quite the opposite. Well, then that again prompts me to say, well, what do you mean by that? That could be something like, oh yeah, I just don't make it sometimes. So when that happens, I can say, well, is that happening pretty often? Do you have that strong sense of urgency to make it to the bathroom with your bowels, without really embarrassing them and saying, are you leaking stool? For a lot of our patients, it's very embarrassing for them to come to us and say, hey, I'm leaking urine, but for them to come directly outright with that information that they're leaking bowels, it takes a lot to pull that out for them. So that kind of prompts me to ask about those questions as well. And then the side effect of, not emptying your bladder well enough on some of these medications like oxybutynin or Detrol, that can happen as well. And so we remember that InterStem is also a great option for those incomplete emptiers. So that, again, this care pathway is so helpful for me because it really helps me to not forget about those other things that sometimes we pass over as clinicians when we're so busy. So then we move forward and we reevaluate the patient. Again, that could be like a bladder diary or urodynamics testing, and then move them forward to those advanced therapies. You see the advanced therapies are kind of listed here on one plane. So InterStem, PTNM, and Botox. And I get the question a lot, does that mean one is better than can you tell me if one is better than the other? And it's always in that whatever particular instance it is for this patient. There's patients that are more apt to go towards an InterStem device, or more apt to go towards the other 2 options here. So I paint these out on the same plane and identify which ones that they might be better candidates for. But ultimately, I like to give them the option to make their decision so that they feel that they're a part of their healthcare here. So Dr. Thompson, can you run us through how you like to use the care pathway?
Well, thank you, Amanda. It's always fun to hear how you use it in a lot of ways to trigger asking them more questions, because it really has function like that for me in terms of actually making my time with the patient move just so much more smoothly. Mm-hmm. So this care pathway actually was came along because of a lot of prodding of myself by someone else. And initially I had this care pathway up on the cabinet doors within all of the exam rooms. Coming out of fellowship, I felt like I had a very good rhythm as to how I talked to patients about overactive bladder. When I brought in InterStim and Botox and PT&M into our discussion, and how I would move the patient sort of through this care pathway that was only in my mind, but I felt like I was delivering that on a daily basis and definitely repetitively to a patient on multiple visits. But when the guidelines came out, I was really prompted by a colleague to put this up visibly. So I said, okay, I'll put it on these cabinet doors. So we laminated this actual care pathway, put it on doors, and we went on for a couple more months. But this colleague kept really pushing me, like, you really need to have this piece of paper and give it to the patient, sort of where the rubber meets the road. And I just was like, I don't really see the point of that. I'm already giving them this information. I guess I'm not sure how this is going to help us. But after continued prodding, I finally did. I made it into sheets of paper that were in each exam room so I could easily grab them. And for a couple months period of time, well, actually, it started out, we were only going to do it for a couple months, and we ended up never stopping. But my APP and I at the time decided, okay, every patient, every visit, we're going to give them this. So we would bring it out of the cupboard and we would start writing on it, just like it is here. I want you to really get that coffee down to 2 cups a day, or I want you to stop oxybutynin, and I would cross it out and put the next treatment we were going to do. And this really was sort of overnight, this realization to me that, holy cow, this is an effective communication tool. And what I was seeing from the patient is they were really focused on what we were talking about. There was less tangential questions about what their aunt used to got for their incontinence, or telling me about this really bad day. And I really felt like all of a sudden I was engaging the patient in a much more effective way. And as they left the office with this piece of paper in hand, I realized, holy cow, they're going to have this to reference back to. And, they only remember about 1/8 of what you say. So maybe looking at this piece of paper, when they get home, they'll remember, one other thing that we talked about. And so it became very empowering for patients, and very just sort of a quality thing that came. So as you can see here, we decided then to sort of look back and say, okay, prior to giving patients this care pathway, how are we doing? How are we doing in getting patients to sort of cross that bridge over to 3rd-line therapy? I would have thought that I was doing a pretty good job, because I would bring it up very early in discussions with patients, even at the time of maybe starting their very first med. And so what you're seeing here is that the yellow bars are from the first half of the year, from January to June of 2015. And the grayish blue bars are from July to December of that same year. And what we saw is that at that turn of the year, about 6 months in, when we started giving myself and the APP to every patient, every visit, the care pathway, we doubled every single 3rd-line therapy. So it wasn't just InterStim, it wasn't just Botox, it was all of them. And so this was proof that what I was experiencing in the room with the patient was actually happening. We were really giving the patient a way to come into our world where we have these guidelines and these standards of care and these safe way of doing things, and letting them listen to it, take it home, think about it, come back, and guess what? The APP is bringing me out this same piece of paper, and we're going through it again. This really must be kind of what the deal is here. And so this 65% increase in advanced therapies, what could that mean for your practice? What could that conversation with that individual patient, how much more effective could that be? And have you feeling like at the end of the visit, hey, this patient's tracking with me. one thing I'd like to say when we're talking about the care pathway is that, there are things in testing, urodynamics, deaf echography, anal manometry, ultrasound, all of these extra tests that we have for patients with bowel and bladder function. But what is most important in these patients is actually just getting a diary. And so I have the diary actually sitting right next to copies of this care pathway in every room, so I can grab them both. And so when I'm sending the patient with their care pathway, I send them with the diary. And guess what? If they come back and didn't bring it, the PA gives them another copy. And that is actually the most effective tool we have. The other testing, while it can help contribute to information about the diagnosis, is not necessary or mandatory to move them along. So with that being said, I think we'll move on to talking about the next steps, which are more of the technical aspects of how we deliver InterStim treatment to patients. And Amanda has quite a significant, robust experience in this, and so I'd like her to talk about the new basic evaluation lead.
Yes, of course, my favorite thing to do. So the basic evaluation. So again, to reiterate what Dr. Thompson said, just handing out the care pathway really was a game changer for our practice. And once that happened, we saw more of a patient load that happened in our office. And it got to a point where Dr. Xavier was having to schedule these basic evaluations on a day he was doing new patients, or a day he was doing urodynamics testing where he was needed to evaluate things. So we were having to schedule them kind of in between things. And so during that time when that happened, we noticed that there was a need for a little bit of intervention. So I would poke my head in and kind of just calm the patient down a little bit, not necessarily because they were anxious, but because they were laying on a table for about 10 or 15 minutes waiting for Dr. Xavier. So poke my head in and make sure that they were doing okay. Just reiterate, hey, make sure you fill out your bladder diary. I'll see you in a few days. We'll go over the results and hopefully we're moving you forward. So that turned into, well, why don't we just have a conversation about me chipping in a little bit? Maybe I could help out some. Along with my rep, she sort of encouraged me to make that move. So had a conversation with Dr. Xavier along with my other physicians at the time. And we decided that I would sort of shadow, and that I would, maybe just help out a little bit here and there. And that really kind of snowballed into a lot more. So we started first off by me marking things for the basic evaluation based off of the anatomy. In our office, we use fluoroscopy, so I was able to use the fluoro and mark, and Dr. Xavier would come in and say, oh yeah, that's exactly where I would put it. And then once I marked, he said, okay, well, you can mark and numb the next one. So I would mark and numb the next one, and here we were twiddling our thumbs, waiting on him again. Again, he was really busy because we had more patients using this care pathway. So once that was done, I marked and numbed, and he said, all right, well, why don't you go ahead and mark and numb and maybe figure out where the foramen is. But that turned into just, one of time we were waiting for that to happen, and I went ahead and placed both. And he walked through the door, saw the image on fluoroscopy, and decided that looks pretty good. He put his sterile gloves on and checked my positioning, make sure your stimulation level was pretty low. And from then on, he just slapped his hands from that and decided, hey, you're going to be doing this the rest of the time, because he was running around like a crazy person while I was trying to help him out. So it turned to more efficiency for our office and a better, smoother flow for both of our clinics, actually. The basic evaluation is my absolute favorite thing to do. We generally stack them on days where I can do about 6 in a row. It makes for a crazy day, but I absolutely love it. Now we have this new and improved lead that we replaced. So we're making this great test a little bit better. And so you can see that here, the basic evaluation, also referred to as a P&E. So we use that term a lot. We can test up to about 7 days. Like I said before, we can do it with or without fluoro, and it can be done in the office or the ASC. Now, the new lead has this high spring, we call it like a slinky action here, where it's designed to have minimal movement. Those of you who are familiar with the old lead, it was a little bit thinner and could easily move out of position if pulled. Now this one, you have to put a good amount of traction on it for it to come out of position. We also have high contrast depth markers. The old ones, they were really tiny squiggly lines that that you would have to really look up to see. Now you can really see these from afar, as you can see right there, and that really assists with the positioning, whether it's the 3.5 centimeter or the 5 centimeter needle here. So, you know, moving forward with the basic evaluation, you know, sometimes the physician may not be apt to give this up because it's a great procedure and they are good at it too. But once you develop a little bit of trust and kind of a little bit more education on placement and good technique, obviously through your supervising physician as well as your Medtronic rep, you can really make a difference here in terms of productivity for your office and efficiency for your office. And if you're not ready, just simply watch a few, get your hands on, see if you like it. And if you don't, it's no big deal. You're still a part of the team, and you're still one who's moving these patients forward to a better therapy and a better quality of life.
Most definitely. I resonate with a lot of what Amanda's saying. I don't use fluoro in the office to place these, but I have when I was in fellowship. So I find you can do them either way. But the thing here that you're watching is a video of the brand new lead on the left and then the older lead on the right. And what's happening is someone is pulling these leads out of the patient's skin. And what you can see is that the old lead moves out very quickly, while the newer lead, those springs start to expand and get further apart, but that it takes much longer, or it takes a little more force to actually move that lead out. And this was really the goal that we were aiming for in the new lead. One of the criticisms of basic evaluations for InterStim is that they're temporary leads and they can move. And so maybe the patient didn't have the best test because of the actual lead or the parameters sort of out of their control with the technique and the technology. And so I was one of the physicians that was asked to work with the engineers to develop a better lead. And so they would come to my office with various prototypes and things, and we would play with them and talk about, hey, this is good, but this needs to be better, or this really wouldn't work. And so it's quite exciting to see this come to fruition. And now when we place these basic evaluation leads, we can have much greater assurance that when we place it, if they're feeling the sensation in the correct area, that lead is going to stay for the length of the test and be much less likely to move out during our short window of time. I also wanted to reiterate what Amanda said about having APPs do the basic evaluation. I did teach my nurse practitioner to do these in the office. She was very eager to do that, wanted to be a part of it. I was a little reluctant as I didn't really want to give up the procedure. I kind of liked doing it. But I think the important point here is that you develop a unique relationship with your provider. And through that, you begin to develop a common language. And I will say that the care pathway really helps to sort of solidify that. And as you develop this common language, you develop this common interest and sort of put your arms around this overactive bladder FI group of people in your practice. And as that relationship grows, things like what Amanda said, where she wanted to just help out. Where else can I be a part of this? This was sort of the next iteration for them. And I think it can be for many, but I think it depends on that unique relationship. And so for me, I decided, okay, you know, my nurse practitioner has been standing by my side. She's been helping me move these patients through the practice. She very much cares about what happens to these patients, and she wants to be a part of it. And so in the end, I worked with her, and she got comfortable placing that. And I realized, you know what, with this care pathway, there's more patients coming into practice. I too don't have time to do all of these. And there was plenty for both of us to do as time went on. So I just encourage you, as we're going to talk here, about starting those conversations with your collaborating physician. I think one thing particularly about the care pathway is that setting up when that follow-up is going to be and who it's going to be with. The APP is sort of the perfect person in my mind for this group of patients to see them and follow up. Having said that, my nurse practitioner saw many a new patient, and I'm sure Amanda does, but the idea that this patient can come back in a shorter period of time than maybe getting on the physician's schedule. And so you can keep close tabs on the patient. If we know these medications are unlikely to work for them long-term, why would we send them for several months without seeing them back? Now we can bring them back and maybe in 6 weeks, touch base with them again. And again, we have this care pathway. I keep wanting to hold it up. I should have brought one. We have this care pathway that then creates this common language between us. And the one thing about the care pathway that I had no idea was going to sort of engender me to wanting to hold this thing all the time was that it spoke to the patient. What I had been trying to get across is that my nurse practitioner or my PA is part of my team. They are going to treat you, and you need to trust that they're going to treat you the same way that I would treat you. And so what the care pathway did was it allowed us to know with each other that, hey, you're going to treat my patient and move them along in the way that I would. And that's going to allow us to have good critical conversations about these patients, about how we want to make it more efficient, how we want to make it better quality. But what it does for the patient is all of a sudden they realize, wait a second, Amanda just showed me the same care pathway that Dr. Thompson did, and she remembers what I did in my last visit with her, and now she's giving me the next step. And I'm not being withheld any treatments. The treatments are written right there. I'm not being told to kind of keep cycling within the medication realm. Like this partnership is really allowing me to move forward. And so what I stopped hearing was, yeah, but I'd really just rather see the real doctor. And that was so effective for not only flow and efficiency through the practice, making sure that patients had access to care in a timely manner, but it really helped us work on things to keep making it a better program, to keep having those collaborative discussions. And so I want to finish with one other thought before Amanda kind of concludes tonight's session. But if some of these things speak to you, for instance, if you don't have a care pathway yet, or you're not sure how to approach that physician, I think that one of the ways to approach a physician that is, in my mind, very unassuming, unintimidating, is to talk to them about this care pathway and maybe even come to them with something that you've created or drawn up and said, hey, I would really like to try this with my patients. Or maybe it's something you can simply try with your patients. And then if it seems to flow well and you're having good feedback with the patients, maybe then you can bring it to the physician and you both can begin to do that. And so I think that would be an incredible way to move things forward, that actual individual piece of paper that you hand to the patient that's special to them, that has their path that's going to happen between this visit and next. And then I'd like Amanda to give us her thoughts about how best to help with that collaboration from her point of view.
Absolutely. I mean, it's so nice to hear you say that, Dr. Thompson. That would, everybody is a team, and that in your practice now, you're seeing those patients come through and trust not only your APP, but you and the whole process. So that really starts with you and your mindset. So thank you for doing that. It really, collaborating starts with the trust and the willingness to learn. And as an APP, I know you're willing to learn. You went through a lot to get to your status. So I know you're willing to learn more and continue to contribute to your team and your practice. So, once we saw the need for it and we acted upon it, everybody knows when you come through our office, you're walking away with something, right? We developed that care pathway. We physically hand it out, and we use it, and we personalize it not only for the patient but for our practice as well. So all of our names are written all over it, including the APPs as well, so that the patient understands that we are a team as well. So you will also want to partner with your Medtronic representative. They are a great asset. My representative has been phenomenal throughout my learning process from day one. She really took me under her wing and helped me use a lot of the resources that come along with it, including the Medtronic Academy. There are plenty of videos and PowerPoint presentations, images, things that you can really hone your own skills on there, and use that. I mean, it's free. It's your discretion. You can get onto the Medtronic Academy website and use all those resources to help you become more comfortable if you're not already there. An on-site or a proctorship is a great way to learn as well. There are a few in the U.S. I am one site. Dr. Xavier and I team together to do these on-sites. So typically what I'll do is walk you through a day of the life of me, and it's so exciting. I know everybody's excited to do it. So we start the morning off with an implant by Dr. Xavier, and then we move into clinic where you watch me with our patients and just shadow and observe the way I talk to patients, walk them through the care pathway, physically use the care pathway, talk about the options. And I think what's important here, kind of what Dr. Thompson said too, everybody's on the same page, talking the same language. It's really important, along with the partnership, that you and your supervising physician are on the same page about the language. Because if a patient is hearing something from Dr. Xavier and then hearing something from me, it doesn't add up. And so you want to make sure everybody's talking the same language. So you'll hear that, and when you come to an on-site, you'll walk through with Dr. Xavier with his talk track, and you'll walk through with a talk track for myself as well. And you'll watch us do the basic evaluations. So, we do them. We have fluoro in the office, but we also, have the opportunity to turn off that fluoro. Sometimes the machine doesn't always work the way you want it to, and electronics don't always cooperate with you. So there are days where we don't have that available, and we can walk through how to do a blind basic evaluation as well. I also walk through how to do some programming with patients. So it really is a day of lots of information, but the day is meant to get you comfortable with the device, with the basic evaluation, with the patient, and how to talk through with that care pathway. Along with that, you have plenty of patient resources that are available. The new handout that says "Say Yes to the Test" is my absolute favorite. Whoever came up with that is genius. Every woman is obsessed with "Say Yes to the Test." And I mean, there can't be a 65 and older year-old one woman who hasn't seen that. So hand this out. There's also a video brochure that's available to contact your Medtronic rep if you don't have any of that. Those have been extremely helpful in my world. Sometimes, physically seeing something and in an animation really helps them understand how this device works and how it can really help them, and how a simple test like this basic evaluation, which only takes about 5 days, maybe up to 7 days, that could really change their life. So, the real big take home is that you're a part of a team, and you have been from day one, right? So hone in on those skills, and if you're not ready, then maybe educate yourself. Again, use all of these resources you see here. Again, your Medtronic rep is really important for that. And they want to see you succeed. They want to help you along the way. Not only does it help them, but it helps your patient and your practice. And I always say the best word of mouth or the best advertisement is word of mouth. And patients talk, and they'll talk to each other, and they'll say, hey, you need to go see Dr. Thompson, or you need to go see Dr. Xavier. They did a fantastic job. But remember, you're also an extension of your surgeon. And so you want to continue to learn. You want to try to further your profession just like anybody else does, but you want to have fun in the process. So know that you can do it, and you have a team of Medtronic behind you. So that's it for me.
Thank you.